a short axis view, you want to be right perpendicular to that long axis of the left ventricle. So that's your ideal setup. The problem is you're holding a transducer in the chest, you're angulating, are you there or are you not? And that brings us to the biggest problem and the biggest limitation with echo, which is foreshortening. So if you're going right through the center of that cavity in an apical view, you can see a ventricle that is somewhat dilated, and it doesn't look too good in terms of function. I think everybody in this room would agree that that is not a normal ejection fraction. In fact, there is even a wall motion abnormality in the inferior wall. However, same ventricle with foreshortening produced by coming more towards the side of the cavity. Now the cavity looks small, and actually the EF appears to be much better. So if this is all you have to read on that patient, you obviously could make some very serious mistakes in interpretation. In an the situation also from the apical point of view is even more complex, because ideally you want to have the transducer at the true LV apex. But quite often that's not possible, because the true LV apex may be way down towards the mid-axillary line. And we end up then putting the transducer in a tangential fashion. And this is appreciated in two ways. One, in the fourth chamber, you get this long axis that is really not as long as you would expect it to be. And most importantly, when you switch to a two-chamber, that apex is way out to the side. Let's get rid of that. Thank you very much. All right. So you have this apex that is pointing to the side. And of course, in a two-chamber, the apex should be pointing towards the transducer just the same way that in the fourth chamber. Once you get that, you know that the transducer is in the proper way. So if you have a two-chamber with an apex pointing to the side, either side, you know that you're not positioned at the true apex of the left ventricle. And then you have patients that have translation, the most common one after cardiac surgery. So in end diastole, you could be perfectly positioned, but by systole, the heart has moved and now you're foreshortening. So this foreshortening problem is really the Achilles tendon of echo that we live with every day, and we try everything we can to try to overcome it. So how do we do that? Well, there are some tricks. These are coming from that guidelines article. You want to minimize translation by having the person breathe easy and not have a lot of big inspirations. You want to maximize resolution by using the minimal depth possible, the highest frequency. Nowadays, a lot of these settings are automatically done by the machine, which is wonderful for those of us who are not doing it every day and don't have all the experience. To avoid apical foreshortening, really, of all the recommendations, the most important is to try to put the transducer right at the apex. And that often requires having a space where you can do that. And that's why in most echo lab, they have a wedge cut in the mattress so you can come down towards the mid-axillary line and really get that position at the LV apex. Problem is, you don't always have that. If you are doing portables, you won't have that advantage. So quite often we come back with an image that we know has some degree of foreshortening. And we saw these two images already. So how do we then, at the interpretation side of looking at these images, how do we deal with it? How do we try to avoid as much as possible making measurements in a foreshortened view? Well, we start by something that Dr. Zogby mentioned last week. Is the first step is to look at multiple views before you start measuring. Don't open a view and start making measurements the first time. And that's the beauty of having some sort of preview. We call it preview, but different companies have different names for the ability to look at multiple views at once, so that you can scan through a study and decide which may be a better view to make your measurements on and which may not be a good one. For instance, right here on this preview, this left ventricular image in a parasternal long axis looks like the ventricle is a little bit bigger and maybe even a little less contraction than this one here, where it looks a little smaller. So you definitely would prefer this one to this one. But then you go through multiple, and you try to select that view that to your eyes and your experience appears to be the least foreshortened. All right? The other important thing is use contrast to enhance the endocardium when you need it. And you need it when you have some difficulties with endocardial resolution, when you see a fair amount of foreshortening, no matter which views you look at, and importantly, when you have big hearts. Because with big hearts, it has been shown that contrast is superior to non-contrast for volume assessment, as I'll show you in a minute. So we get to the assessment of a size of a left ventricle, and to this day, dimensions still are important. They're still done in a daily manner, and this is from the guidelines. And if you have a perfectly set up image, where in a parasternal position, the left ventricle is perpendicular to the imaging plane, you can use N mode. And N mode gives you very nice resolution, and you can make your measurement from N mode. Problem is that in reality, quite often, we have an image like this, where the apex is tilted, because in order to get the best quality view of the left ventricle in a parasternal position, you had to bring that transducer down just a bit. And once you bring that transducer down just a bit, the heart gets angulated, and the apex starts pointing up. So now, if you were using an N mode, you would be doing a tangential cut through that cavity, and you would be getting a falsely bigger LV dimension. And that's why, in most cases, we end up measuring directly off the 2D image, because you can very easily, in your mind, set up the long axis of this heart and then do a perpendicular measurement. Now, this is very important, because I see still with our sonographers and our fellows that even when they do a 2D, they don't quite do that. So again, in your mind, you have to set up the long axis of this cavity, then do your measurement perpendicular to that long axis, not in any other way, because a lot of you, I see you still doing measurements that are tangential. Remember, the heart grows with the body size. So whether you are a man or a woman, male or female, the bigger you are, the bigger the dimensions tend to be. And this is from the guidelines, and most people have these things in their lab so that they can relate to them. But the important thing is that a big fellow, and we have a lot of those big fellows around here in Texas, a big fellow with a BSA of 2.5, 2.6 can have an end-diastolic dimension of 6.1. And it still is in that upper limit of normality for that particular person. Okay, it would not be normal for someone with a much smaller body. Same thing for ladies. Now, women in general have smaller LV dimensions than men, but within them, likewise, it gets bigger with a bigger body size. So a big lady in a 2.2, 2.3 BSA can get up to a 5.7, 5.8. So keep that in mind, again, when you're making your interpretations and making your sentences as to whether it's a normal. I see a lot of comments by fellows with a 5.2, 5.3 saying enlarged left ventricle. You look at the body size and it's a big person. So keep that in mind. Now, having said all that, the standard, the best way to really know if a left ventricle is dilated or normal is through volumes. I mean, that's really is ideally what we would like to do as often as possible. And to this day, although there are some newer tools that we're going to discuss in a minute, to this day, the method of disc is still the standard that we recommend. In this method, basically, the left ventricle is divided into multiple little discs, equidistant of each other, and the computer calculates the area within each of these discs, and then creates a volume for that disc, and then adds all those volumes together using a very complex equation that would take a whole day for one case if you did it manually, but it takes seconds for the computer to do. If you're doing a single plane method of disc, then the system assumes that the other plane is going to have the same measurements as this one and just duplicates them in that way. Obviously, the more accurate method is to incorporate both the 2-chamber and the 4-chamber, and then it uses these measurements in 4 chamber with this one in 2 chamber, and again, calculates the volume in each of the discs, add them up, and that gives you the final volume of the heart in diastole and in systole, okay? Now, notice that in this example, the apex on both views are pointing up. So this is a properly done view where the transducer was at the apex of the LV. Also notice that the way we're tracing is a little different from what we used to do many years ago, because we have learned with the use of contrast and with comparison with MRI and CT, that if you trace through the first borders of the endocardium that you see, you will foreshorten the cavity and get very smaller volumes. And therefore, we have all now learned to go further up, okay, both in diastole and in systole. How do we know that we have some accuracy? Well, if the patient does not have significant mitral regurgitation, then the stroke volume by Doppler should be similar to the stroke volume by 2D. And that is our internal control that gives us an idea. And you like to be as much as possible within 5 cc's. So you have a 75 in one, 72 or 71 in the other one, or 70, you know, you're okay, you're in the ballpark. But if you have 75 in one and 55 on the other, one of the two have a problem. You don't know which one, it could be the Doppler, but there is a problem that you need to go back and recheck. So again, this is from the document, and I think we have these things pasted in the wall in the Echo Lab. Everybody tends to have them. These are your basic normal ranges and mild, moderate, severe. Again, it's better to do it corrected for BSA because you're already incorporating the person size, and these numbers are there, and we use them on a daily basis to assess the degree of enlargement of the ventricle. So here we have a very nice example on an image that this image is not terrible. In fact, it was good enough that without contrast, the images were stopped and tracing was done in diastole and systole, and we came out with an end-diastolic volume of 200 cc's and EF of 36%. However, notice that when contrast was used, even without measurements, your eye can tell you already that this is a lot bigger cavity. And in fact, now when we trace through using the contrast borders, we get a much bigger end-diastolic volume, and EF dropped. And of course, this is very important if you are using EF as, for example, a guide towards ICD implantation and so on. So this is a nice example because the image was not terrible, and yet with the contrast clearly showed a bigger heart, and actually in this particular case, a drop in ejection fraction. So that's why, again, for the sonographers, when we're dealing with big hearts, particularly patients with cardiomyopathy, patients with mitral regurgitation, aortic insufficiency, and I don't mean a trace-off. I mean, when we're concerned about the severity of these lesions, we like to use ventricular volumes, as we will show later in other conferences, as a way to do some measurements for ejection fraction. Contrast becomes very, very useful, if not even mandatory. And this was shown many years ago. Back in 2001, at the Mayo Clinic, they did a study using CT as the gold standard. And you can see that without contrast, there was a correlation of volumes. But an end-diastolic volume of 200 by CT was about 130 by 2D. When contrast was used, not only was the correlation a good correlation, but now the regression line and the line of identity were very close to each other. And the hearts became bigger, and the numbers were more in concordance with the CT numbers. All right, now we have 3D, and this is a very early slide. I think Dr. Zogby may have shown something like this last week. This is the old 3D that used at least three bits that were stitched together, and then created what still looked like a very nice shape of the LV and contraction, and then you get the numbers, volumes, and ejection fraction. And boy, that looks like fantastic improvement and ability to do things more routinely. Well, a very important study was done back in 2008. It was a multi-center study using CMR as the gold standard, involving several labs, so they have a good sample size. And lo and behold, there was good correlation between the volumes by 3D and by CMR. So this is 3D, and this is CMR. And overall, you take a glance, not bad, okay? The problem is the discrepancy. So here's the ejection fraction. So yeah, not a bad correlation, but now you have these outliers at both ends. So here we have EF by 3D that is in the 50 to 60 range, but in the 40s, maybe below 50 by CMR. Likewise, the opposite. Here is a group of patients that had CMR EF in the 50 to 60 range, but they are in the 30 range by 3D. So if you are in a one-to-one situation in the lab, and now you have this case, how do you know? How do you know the accuracy of that one patient? Thank God there's been improvement, and technology. It's amazing the degree of improvement that ultrasound does. If you remember last week's lecture by Dr. Zogby, I mean, we started with a little bit of sound that gets bounced, and now we have this amazing potpourri of electronic technology using digital techniques, where now they can actually do something called auto-contouring algorithm and end up with one bit, a single bit volume EF, which allows us then to do even left atrial volumes and RV volumes and whatnot. Certainly, this new technique has improved the accuracy. As you can see in this one particular study, you can see the data is a little bit tighter. But even as tight as it is, when you do the blind Altman, there's still a fair amount of individual discrepancies. Here we have a patient with a 70% by CMR, but barely 50 by 3D. So you still have this one patient situation. You're saying, okay, who do I believe? Do I believe my eyes? Do I believe the 3D number? If you are a very experienced EF estimator, like many of us are here, then you would believe your eye and basically get rid of the 3D number if you don't believe it. But the problem is, when you take this to the big use by everybody, you can see where the problem could be. So let's do a real case, real time. This is a patient in the echo lab, nice quality. We would all love if all of our echoes were like this. Our life would be a lot easier. So we get the apical views, and we trace them. This is manual tracing. Again, using the newer techniques of excluding a lot of these endocardial trabeculations. And we end up with an end-diastolic volume of 116, normal. Stroke volume of 77, looks very normal. EF 66%, which I would suspect many of you with your eye would have said something like that, mid-60s or so. All right? Well, here's the automated LV volumes. End-diastolic volume 52, stroke volume 30, 59%. So it's normal EF, but there's a difference between 59 and 66. And the question comes in, well, was this just that the sonographer didn't quite place the positions in the right way? Is this technical, but the images were good quality? Now you're done, you get this number, which number do you accept? I think most of you, with your experience, would say, we need to throw this away. But will everybody do that? So that is still the limitation we have with the 3D volumes and EF. We should use them because we need to learn how to use them. The sonographers have to learn how to process them. But we still have this situation. First of all, we need good images. It's very hard to do when your images are suboptimal. Number two, you cannot use contrast because the system gets all confused. And then the same thing, when you get a number, how do you know the accuracy of that number? You have to basically rely back on your experience as an estimator or do the manual measurements. Well, if you do the manual measurements, why did we even bother then with the 3D? So we still have this issue that have not yet been resolved despite 3D being around for a number of years.
I think part of the problem is contouring.
You want to get a microphone, Bill? Somebody has a microphone to bring over, an extra one? Because I don't. Well, I can give this. No, that's not. Here we go. There's a mic coming. Yeah.
The problem with the 3D is nowadays we gradually adjust it to trace the endocardium further in and ignore the trabeculations.
Yeah.
The 3D, the automated 3D contouring of the endocardium is not yet adjusted to
Mm-hmm.
So you're going to have to adjust it manually, and you'll get bigger volumes, and you'll still get a decent EF.
Right. So for the sonographers here, if you have trained your eye to do a reasonable estimate of EF, and then you do your 3D with the patient there, and you get a number that doesn't make sense, that's telling you that there's a problem and that maybe you need to go back and readjust those thresholds. So use your eye to guide you also, because many of you are experienced, and you know if an EF is in the 60s or in the 50s or 40s. All right, let's talk a little bit about strain now, which is the new child, the new kid in the block, but not so new anymore. It's been around for a while. And like many other things we do now in echocardiography, strain is a product of the digital technology. So in essence, you have a digital matrix like you have in your home TV that have pixels. So in those pixels, you can identify one spot in the myocardium. And now, what the system has done that is really amazing is follow that spot from diastole to systole, so how much it moves. So you have a spot here and another one here. You can do the distance between them, the two of them, and see what happens to that distance from diastole to systole. But you can do that all across in multiple little pairs of those two spots, and you follow them all the way through the myocardium, and then incorporate them into some sort of global and regional assessment. So strain is basically the change in that distance divided by the initial distance. It's basically a volume displacement or a dimension displacement of that small area of the myocardium. Velocity is dividing that by the time between them. And of course, there's always noise in these techniques. So when you put time and you put it into a strain rate, you do increase the noise. And therefore, there is a little bit more issues with reproducibility, accuracy. And that's why strain rate is still out there, not in prime time. But strain, which is just the percent displacement, clearly, with all the technological improvements that we have nowadays, is coming into prime time. So we have three strains: radial strain, which is strain along the thickness of that wall. So basically, it's looking at the percent thickening of areas within that myocardium, and therefore it is a positive curve. Circumferential strain in a short axis is strain along the circumference of that ventricle, and therefore it shortens itself, and because it shortens, it's a negative curve. And then longitudinal strain, which is also negative because you're looking at shortening along that long axis of the left ventricle. So again, you get a negative curve. Now, it turns out, when you look at the way the left ventricle, actually the heart myocardial fibers are set up in that beautiful spiral way that has been shown so nicely in multiple other lectures, and this torsion phenomenon of the heart that has been very nicely demonstrated. It turns out that even with LV dysfunction, circumferential contraction is preserved. So you have a lot of hearts that have pretty decent circumferential shortening, but they have pretty lousy longitudinal shortening. And among other reasons, that's probably the biggest reason that longitudinal strain today is more popular, more being used on a daily basis, as we're going to discuss in a minute. And the circumferential strain has been less, again, because of the clinical applications, given that patients with HFpEF, patients with hypertrophic hearts and whatnot, will still maintain a good circumference of contraction. And you see that. You don't need a strain to know that, because you do a short axis imaging and you see that beautiful contraction of the heart in a short axis. So this is the longitudinal strain, and this is a nice normal. And then you can see that there are multiple spots where you can do the measurements. And so you end up with multiple curves for each of those segments that were evaluated. And then you have an average curve, and then the number would be the average of all these curves, all right? And you get a peak. So right now, what the system gives you is the average, peak, global, of all that view there, longitudinal strain. And in this case, it's 23%. Now, strain is a vector. And actually, it could be moving even away from the screen. So in theory, a 3D GLS would even be more accurate. And in fact, there are some machines nowadays capable of doing that, but it's still not, again, something that is available in every machine and that we're using daily. And of course, it's going to be even more tricky because now you incorporate a lot more need for time to process and need for very good imaging so that you get a good assessment. So for this, up to now, two-dimensional GLS is still kind of the standard that we're working with. But I want you to know that there is, in fact, a 3D because those vectors can be going in directions that are even away or from the screen. All right. Now, because you make all these measurements in 3 views, apical long axis, apical 4-chamber, apical 2-chamber. So all of this gets incorporated into the 17 segment model, and you get this nice bullseye with the values for each of those segments, and the average is for the entire heart. So in this case, the average is 21%. There's a negative sign because it's a negative curve, and we'll get to that in a minute. So here we have a bad heart. You don't need strain. You can see the image and you know, oops, that heart is not good. But it's interesting, when the strain is done, the GLS is done, notice in this particular view, which was a 4-chamber view, that there are, most of them are still negative, except the peak values vary, but even one segment was positive, meaning that it was actually dyskinetic. So you begin to appreciate more type of desynchrony of contraction, even in a cardiomyopathy that could be non-ischemic. This patient doesn't necessarily have to have coronary artery disease. This is seen also in non-ischemic cardiomyopathies. So you see this heterogeneity of contraction in multiple segments. And of course, again, the average of all that is 6.2, which is a pretty depressed number. Well, this is a sort of an editorial that was put together in 2019 by a group of experts that included our own, Dr. Zogby there, and talking about something that we all have been saying for a long time, but we needed a small group of experts to put it out there in print, is that a minus 20% is mathematically lower than a minus 10. But we all know that 10% is actually lousy compared to 20%. It's depressed. So to eliminate this confusion, they all recommend that we get rid of the sign. And just basically I talk about 20% and 10%. In fact, ejection fraction is a negative value. You go from an industrial volume of 120 to one of 60. So you're going down on volume. Whoever would have talked of an EF of minus 60%. So again, it's the same concept. Let's be practical. So 2 recommendations were made by the group. One was to get rid of the sign. And number 2, again, to try to eliminate the confusion is to change the term to global longitudinal shortening rather than strain. I don't know that that second one had yet become universal, but that's okay. If we got rid of the sign, we're happy. Now, these publications, some of them still have the signs because they're older publications. So this is an important publication, is the fact that looking at large samples, 2 things are picked up. 1, there's a little reduction in GLS as we get old. So I do not want to measure mine. But there is a slight drop as the heart gets more senile. In addition, there is variability between machines. I will show you that in a minute, okay? If you do the same patient with 2 machines, GE versus Toshiba and whatnot, there will be variability. That's the second important point. But regardless of age and regardless of variability, no one that is normal goes under 16. Everybody is at 16 or higher. Okay, that's a very important point. And when they look at vendors, they found that in general, using TomTec, which is a post-analysis, post-imaging analysis using the TomTec machine, gave the highest value. And that was followed by GE, then Toshiba, then Philips, and then Siemens. But regardless of all that, less than 16% was myocardial dysfunction because no normal had a value of less than 16. So for that reason, the recommendation had been 17 or higher, normal, 16 to 17, low normal, like we have with EF, under 16 is abnormal. And this is important because I still see some reports from you guys saying abnormal strain when they are like 17.2 or something like that. So let's all agree on what are the recommendations. So an abnormality of strain, GLS, is under 16. 16 to 17, low normal, 17 or higher, normal. All right, so what are we using this for? Well, clearly, the beauty of this technique is allows us to pick up subclinical myocardial dysfunction in a variety of diseases. It's somewhat objective because it's done by a process of the machine. Doesn't mean that it's perfect, doesn't mean that I cannot screw it up, but it's more objective than our eye. And most importantly, as we're seeing with more and more diseases, it gives us a better prediction of serious cardiovascular outcomes compared to the standard of 50 years, which is ejection fraction. And then there are regional patterns that will help us also detect diseases and, of course, coronary artery disease. So this is an example that I always love to show because this is an ejection fraction of 90+%. I mean, this is complete cavity obliteration in a young hypertensive man who, of course, also had, as you can see from the calcium in the annulus, also had end-stage renal disease. So you have a phenomenal ejection fraction. You have a big left atrium, which tells you that there is some diastolic issues. And here's the strain. It's 14.2, clearly depressed, number one. So global strain is depressed. And also, you can see that there are regional areas that are really bad compared to others, okay? Everywhere you're down. I mean, the best number was 17. But everything is on the low side, but here in this area, you're really, really depressed. Now, could that be an LAD lesion? Maybe, because it's covering this area here, or the right here now is beginning to get into the right coronary territory. But you know what? This patient could have perfectly normal coronary arteries. This all could be intramyocardial, either because of myocardial coronary reserve issues or because just myocardial fibrosis and whatnot. So the first thing is, this is very helpful in knowing that this heart not only has a depressed global, but has areas that are even worse, which we still have not gotten into a consensus on how to report this. Sometimes I do it. Sometimes I say, GLS is reduced to 14% with regional changes in blah, blah, blah. I sometimes make that point whenever it's very, very impressive. But we still are kind of learning how to apply that regional number to the global number. So this is the list that is still growing of diseases, conditions where longitudinal strain is depressed, people who are hypertensive, particularly with LVH, hypertrophic cardiomyopathy, in diabetics, interesting, transplant patients, chemotherapy toxicity, a lot of valvular lesions, end-stage renal, as I just showed you, HFpEF, very important, and sepsis. And the list keeps growing. There are more and more conditions where people are reporting abnormalities. But the important thing is that in practically every one of those reports, clinical outcomes tend to be worse when people have reduced strain. So we're going to start just for historical reasons with the cancer chemotherapy because that was the very first one that started to put longitudinal strain in the map, although it's, to this day, it's still working its way through and not perfect. So basically, if you're giving chemotherapy agents that are toxic to the heart, and you get a drop in GLS between 10–15% or more, that is suggesting that there could be a problem and that down the line, the EF may drop or the patient may even develop heart failure. But the sensitivity and specificity for that is varying between studies. If you get an absolute GLS value under 18%, particularly if it's, again, it started with normal and now you get an absolute value that is down, that also had a similar sensitivity and specificity, but varying. It's not, every study doesn't show you the same thing. And even starting with a reduced GLS could be a flag for patients being at a higher risk for chemotherapy-induced cardiac toxicity. But the problem with this is that when all these studies are put together, there's so much variability that from the point of view of the oncologist making a decision with the help of the cardiologist on how to treat that patient, ejection fraction continues to still be the hallmark. So usually it's a 5% or more drop in EF. And of course, that requires a lot more accuracy in the EF assessment. So although this was one of the very first uses of global longitudinal strain, we're still wrestling with where to put it. And therefore, ejection fraction continues to still be what most oncologists and cardio-oncologists, cardiologists are relying on. But this is where the GLS appears to really have a lot of strength. This is already an old study from 2018 by Potter. But show here is ejection fraction versus mortality in patients with heart failure. And you can see here that there is a range. Here are patients with high mortalities that have EF 55 to 60. And in this group between 50 and 35% or so, there's a lot of variability in the outcomes with the EF not showing much. Sure, once you really get to under 30%, yeah, there is an increase in mortality. This is actually just mortality, so it's a very solid outcome. This is one of the papers that put the GLS in the map in terms of heart failure management. Over 4,000 patients in 2018. And again, this was a combination, a combination of HFpEF and HFrEF, actually close to 50%. I mean, it was a very well mixed group of HFpEF and HFrEF. And what you see here is the probability of death with EF. Okay? And this is with GLS. And you can see that the big crossover, again, is around 16. Once you hit 15 or less or so, now the curve becomes very steep in terms of outcomes, with mortality being the primary outcome, which is a very solid outcome. Then this is another study published a little later in 22, where these were people already optimally treated. So they were in the guideline-directed optimal management, most of them class 1 or 2. So they had responded, they were happy, they were taking their pills and doing their thing. And the sample size was a little bit over 300 patients. All of them had dilated cardiomyopathies, non-ischemic. And again, those that had an EF less than 40% and a GLS less than 13 had the worst outcome, all right, in 10 years. But notice that the curves separate quite early. By 5 years, there's a significant separation. If you have an EF over 40 and a GLS over 13, you had the best outcome. But interesting, people with a better EF greater than 40, but a low GLS had as bad outcome, as bad an outcome as those with a EF of less than 40. So again, in showing the power of a strain over ejection fraction in this group of patients that were all on their proper treatment and doing okay. So I think clearly our heart failure groups are beginning to look at this with more length into it. The question that we still have with all of these measurements that gives us some sort of prediction of outcome is, what do we do with the data? So we know now we have this patient that is a much higher risk by the data. But do we have a magic pill to give them? Do we have something new? Do we put them in a transplant program sooner? So the clinical decisions of what to do with that information is still needs to be resolved. But the data is becoming very strong that global longitudinal shortening is certainly more powerful than ejection fraction in predicting risk in heart failure patients. So now we move to valvular disease, and this is one of the early papers in severe AS, asymptomatic. asymptomatic severe AF, and they show that people with GLS under 18%, okay, had a higher event rate over 5 years or so than those that had a normal GLS, and the time to valve replacement was faster in that group. Again, these were asymptomatic people with severe AS. But then this next paper really made it even more challenging in terms of scratching our head on what to do with these patients. This is now moderate aortic stenosis, 760 patients, defined as a peak velocity less than 4, a mean gradient less than 40, and they were followed for 50 months. They only look at mortality. So EF 50% or better with a GLS over 16 had the best outcome. EF less than 50%, the blue curve, a bad outcome compared to the other one, but a good EF with a GLS than 16 had as bad an outcome as the low EF. This is moderate aortic stenosis that we normally have been saying, well, we'll follow you and see how you're doing and whatnot. So we take a closer look at the asymptomatic group, and this was, so here is everybody together, but this is now specifically looking at, within the same 700 plus patients, at the asymptomatic patients, happy patients with moderate AS. And again, very significant outcome with a GLS under 16%. So all this data now are being thrown at the experts to try to say, what do we do with this now? How do we change our thinking, our management, now that we have TAVR, for example? So this is you guys are in a very exciting time of cardiology, because all of these things will be changing our approach to therapy for sure. And this is just from the same paper, again, showing where the cross occur. And again, this is 15, this is 16 somewhere in here, and you can see where it changed, and then bingo. The lower the GLS, the higher the hazard ratio for mortality. This was one of the first papers with mitral regurgitation, and in this paper, for some reason, the threshold was 21.7, but those with less than that value that were followed had a higher proportion of death, and that included post-op also. And this is important because we know that with mitral regurg, when we correct the MR, EF always drops a little bit, and then over time it tends to come up, okay? But what happened here is that if you see the people with a good GLS of 18 or more, they had an EF in the 60s, they all dropped immediately post surgery, but then on long-term follow-up, they jumped up again to not quite, but pretty normal. Those with a low GLS, they started with a lower EF, even though it was quote-unquote normal, but low normal, then they dropped a lot more, and they never recovered perfectly well. So again, another way of seeing the prognostic impact of global longitudinal strain on patients with mitral regurgitation. And in the same paper, when they look at cardiac events after surgery, this is all after surgery, going solid with good numbers for at least 5 years, but some patients went even longer than that. Cardiac events and all-cause death significantly more in those patients with reduced strain under 18%. It's interesting that for mitral regurg, the threshold is higher than for heart failure and AS. It's under 18, so it covers some of that gray area that we call low normal. And it may have something to do with the mechanics of mitral regurgitation. Now here we have another interesting paper. This is very recent. This is from about a year or so ago, in sepsis. And using strain and using 17% as a cutoff, okay? Those people, this is sepsis patients with preserved GLS, all right? Time to death within 28 days, okay? Survival. And of course, it's a short outcome because it's sepsis. You're talking about, what's happening acutely with the patient in the hospital. And you can see that they have a reasonably decent outcome, and those with a reduced GLS and worse outcome acutely. So even in the setting of sepsis, which we know is a condition that can affect the myocardium, measurement of GLS may give us also an indication of a higher risk group of patients that might require different patients. So finally, let's talk a little bit about the regional component of GLS, and this is classic. You all recognize this one. This is your patient with amyloid that have the apical sparing, where the apical segments have much better contraction than the mid and basal segments. This is a patient with ACM, apical ACM, very nice. You see the contrast to the echo, and you see the CMR, both having a lot of agreement. And when you do the to the echo without contrast, you could miss it. In fact, it's often missed without contrast. But the strain clearly shows you reduced values towards the apical segments. All right. Regional one motion, we all have trained you guys to do a good job with assessment of regional one motion by looking at movement of the endocardium as well as thickening of the endocardium. This is a patient with a significant inferior posterior abnormality seen well in the apical long axis, apical short axis, and in the two-chamber view. It's an all infarct because you see some brightness and some small reduction in thickness. And these are the typical assessment of wall motion. You all know this very well. We do it every day. And this is the coronary artery distribution score that we use, where we have different segments depending on the artery that is supplied. Hopefully you all know this very well. With the RCA and the circumflex, of course, sharing some segments depending on the dominance of those vessels. This is the typical scoring the computer does. 1 for normal, 2 for hypokinesis, 3 for akinesis, 4 for dyskinesis, 5 for aneurysmal, and then all this sum divided by 17 gives you the wall motion score. So how does strain help us? Well, strain can help us by actually bringing us that maybe something is going on that the eye didn't quite pick up. Is this area abnormal or not? Is this hypokinetic? Or is this just a little bit of heterogeneity of the inferior wall? Well, look at this global strain. Very, very impressive in this territory. In fact, the strain was more impressive in terms of the regional component than the eye was. This would be a patient that I would make a comment about that. I would say GLS is reduced to 13% with significant worsening in the infero posterior region to bring to the clinician, bring that component up. This is somebody with a bad ventricle, a low EF, but in addition, an inferior wall that appears to be akinetic. And again, look at the strain patterns. Very, very prominent in this region compared to the LAD regions, even though the whole ventricle is depressed, and of course, the GLS is 10%. Here's one that the apical contraction is not quite that perfectly seen, although suspicious that there is maybe a problem here, but this is very dense and very significant. And this is one that is even more impressive because the 2D echo was not quite that helpful. The images are not your best. EKG suggested an all anterior MI, but again, it's one of those that, is it or isn't it? So the strain had this area here of very low values compared to the rest. The peak GLS average was still in the normal range because everything else was great. But this area was very suspicious. Contrast is used, and sure enough, there is the tip of your apex. It's abnormal. So again, where the GLS comes in is that it gives us a warning sign that maybe there's more than the eye can see. For the sonographers, if you're doing it, that should be one of your other hints to use contrast. This is the apical ACM. I think it's the same one that I showed you earlier. Just to, again, bring the point that not all regional abnormalities are caused by a coronary artery occlusion. There's all these other conditions that can also give you a regional abnormality. So summarizing, the potential applications of GLS were detecting subclinical dysfunction in a variety of diseases that has been very well proven and shown. provides a better prediction of bad events and mortality than EF. It has been very well shown, as I showed you before. It's a more objective assessment of regional and global function, and it may help us in detection of regional abnormalities in bread and butter CAD by, like I said, giving us a hint and making us look further. The problem here is, as I said earlier, what do we do? So limitations. First of all, you still need some decent quality, number one. Number two, it is an index of fiber shortening, and therefore it has been shown to have some dependence on loading conditions. For instance, it's always recommended to have your blood pressure reported at the time of the echo when you look at strain. And they've been shown that over time, variations in BP can alter some of these numbers. So it is not 100% load insensitive. It has some loading sensitivity. The biggest problem is inaccurate results may be incorrectly accepted. So the problem is you have a normal echo. Everything looks great. And the GLS comes in now 14.7. What do? Do we report it and make everybody worry about something that we don't know if it's real because everything else it looks good? Do we automatically do a CMR? Do we throw a $1 million workup in that patient, or do we throw it away? And on the daily basis in the echo lab, we have those situations that we have to make decisions on what to do. Everything looks great on the echo, but the GLS looks. Because there are technical things that can happen, just like we talk about in 3D. In the processing of that GLS, also, you may not be in the perfect setup of putting where the targets are in the different views, and you may end up with a falsely reduced value in otherwise a normal heart. Personally, if I'm in doubt, I throw it away. I don't report it, because I don't know what to do with information. If that clinician calls me and says, Mike, what do I do with that number? I'm going to say to him, I don't know. So why throw that when we have no idea? So personally, that's what I do. Now, each of you have to make your own choice. The biggest issue is still what I said earlier. How do we treat asymptomatic patients that had abnormal GLS, and how do we bring this new data that we have of the prognostic impact of GLS in all of these diseases? How do we bring that into an action? Do we do valve replacement sooner in a moderate AS because their GLS is low, or in a patient with mitral regurg? Do we incorporate other therapies in a HFpEF because their GLS is lower? How do we manage that? And of course, that's going to require a lot of work involving the experts in the clinical settings of these diseases. And with that, I thank you for your attention, and we have a few minutes for questions. Dr. Cha.
All right, thank you so much. That was a really outstanding overview. Two questions for you. One is there any role for looking at GLS in the setting of exercise? Where oftentimes, I know in stress echo, it's hard to say, is there a Walmesh abnormality or not? Has anybody looked at this to say, is there any value in this?
Yes, and in fact, there are publications, and I didn't put it because it's still finding its way to prime time. Why? Because it's become extremely hard to do it with exercise because of quality of images. We like to use contrast often, that throws everything away. So the publications have been mostly with dobutamine, which we are not using that much anyway. But in that setting, yes, it has been shown that failure to improve GLS with certain thresholds, I would have to look it up to remember, was quite accurate in predicting disease in the. So they had studied where they had the eye expert do their evaluation, and then the strain measurements, and it came out very good. But it's dobutamine, without contrast.
Great.
Which, it limits tremendously our day-to-day use.
Okay, and then the other question I have, ultimately what you're measuring here is kind of longitudinal shortening. How about just a simple measure like MAPC, myocardial angular plane descent? Kind of like what you do for CAPC on the RV?
Yeah. So, yes, in fact, it is. The thing is, you're correct. In fact, the apical displacement of the mitral annulus in, for example, patient with HFpEF is often impaired, but it's also impaired in elderly patients. So that number, and that may actually have some correlation with the slight reduction in GLS that is seen in the elderly. The problem is there has not been the same prognostic impact of that value that the GLS have had. Maybe because the ranges are a lot smaller. I mean, with displacement of the annulus, you go from a number of like 1.52 centimeters to maybe a 1 or less. Some patients, it's almost 0. But to my knowledge, I have not seen anybody being able to measure that in a same setting as the GLS and then have the outcome assessment. So, Bill, have you seen any? Because I haven't seen any papers. You know, maybe there's something there for a fellow to do.
Obviously, these are related, right? This is the integral of the shortening of this heart. The other ones are percent change, right? So the difference conceivably is that a percent change may be less dependent on the size of the heart. So if you have a smaller heart, the descent of the base may be a little less than a bigger heart, although both of them may have normal function. That's the difference. And two is, the other one is more regional. If you do a MAPSI, it will most likely be almost half of the heart that's influencing that portion of the annulus, as opposed to the GLS, which includes the septum or the other areas that you're dealing with the heart. Just to put it in perspective, why would GLS be very important from a prognostic point of view when you have a normal cardiac function as measured by ejection fraction? Think of, in the past, we've reported that if you have normal EF, you have better prognosis, but in those patients who have normal EF, and if they have hypertrophy, they have worse function, they have worse outcome. Basically, GLS incorporates function and conceivably some irregularities or problems with the myocardium. Take a hypertrophied heart, just simple hypertension and hypertrophied heart, they're going to have a normal EF. Take a look at the descent of the base, is much more reduced. And these are the patients that may be normal EF, but reduced GLS. And where does the EF, how does the EF preserved if the descent of the base is altered? Because of radial shortening. So if you take a look at them, the radial shortening is quite impressive, but the longitudinal shortening is much less because of alterations in the endocardial fibers of the heart. So in a way, it incorporates function and also deformities and abnormalities in myocardial structure that is telling you that is prognostically significant.
A couple of potential studies for the fellows that are listening. One is not that difficult, it just takes a little bit of work. We have wonderful data from the CMR lab in terms of interstitial fibrosis and outcome of diseases. That data is already there. We just need to find the patient that already within a reasonable time had an echo with strain and sit down and look at it. Because there may be a signal there that may be worth looking at and reporting. And the other one could be what Deepan just suggested, to be honest. You know, you could take the long axis of DLV as the denominator, and in the numerator put the displacement of the annulus, create a percent number, see what happens. Maybe there is a signal there too that might be worthwhile. Those are two simple projects for any fellow that is listening that may want to do a little bit of work. All right. Any other comments or questions? Let's go back to work.